And we asked Dr. SANGHAMITRA to talk on retinal vein occlusions. Though the time given is 6 minutes, but I think if we speed up, it will be good for everybody.
Good evening. I would be talking about cataract with retinal vein occlusion. So we would be discussing on what should we watch out in the anterior segment. Is fundus evaluation important before cataract surgery? What if the fundus picture is hazy? Role of FFA and angiosity, and role of intravitreal, that is anti-VEGFs and steroids. As we all know, cataract surgery increases the arachidonic acid and prostaglandin pathway, thus increasing vascular permeability, leading to cystoid macular edema. Abnormalities in the superficial and the deep capillary plexus were common in RVO patients. Thus, patients with RVO would be more prone to the development of macular edema when compared with their counterparts without RVOs. So in the anterior segment, what should you look into? You should look at the pupillary reaction. This would give you a clue whether it's ischemic or non-ischemic. Look for NVIs and NVAs in the angles, and intraocular pressure, of course, because many of these are predisposed to have glaucoma. So how do you look for the NVIs and NVAs? NVI would be looking at the pupillary borders, the fine frilly vessels that are there. In the fundus evaluation, are dilated tortuous vessels with hemorrhages in all quadrants, a hyperemic disc, soft exudates, and macular edema would point out towards central retinal vein occlusion. Dilated tortuous vessels with hemorrhages in one quadrant would point out towards branch retinal vein occlusion, and both of these might lead to vitreous hemorrhage if they are ischemic. Now, this was the first case, was a 55-year-old female suffering from hypertension for the past 10 years, defective vision for 1 year. Best corrected visual acuity was 6/24 in the right eye. As you can see, there is an inferotemporal branch retinal vein occlusion with some amount of a suspicious new vessel like over here. So when we did the angiosity, we could see the new vessels over there with the adjoining CNP areas. So this patient who presented for cataract surgery underwent intravitreal injections along with sectoral PRP. So this was a 68-year-old female, again presenting for cataract surgery, a known hypertensive and diabetic for the past 12 years, with a defective vision for 6 months and intraocular pressures of 18 millimeters. Best corrected visual acuity in the right eye was 6/60. As you can see, there's a dilated tortuous vessels with macular dull foveal reflex. She had a CRVO with macular edema. When OCT was done, it showed a huge edema with loss of architecture of both the outer and the inner retinal layers. So when angio-OCT was done, it showed a gross macular ischemia both in the superficial and in the deep capillary plexus. Now this was again a 75-year-old female, known hypertensive for 10 years, had open-angle glaucoma on travertan. Intraocular pressures were 16, well controlled with anti-glaucoma agents. Best corrected visual acuity was counting fingers with the grade 3 nuclear sclerosis. As you can see, the disc was suspicious. There was open-angle glaucoma over there, and there was some anastomosing vessels in the disc margin. So when an OCT was done, it showed disc edema with traction over the fovea. Anti-VEGF, she was treated with the anti-VEGF agents, and post-anti-VEGF, there was a vitromacular traction. So she underwent cataract surgery along with vitrectomy. So role of anti-VEGF, you see, the risk of post-surgical CME in uncomplicated cataract surgery was 30 times higher if the operated eye had a history of RVO. This risk persisted even in eyes without preoperative macular edema. So patients with cataract who are actively managed for macular edema due to RVO with anti-VEGF agents may undergo cataract surgery. So this was my last patient, a 72-year-old male, a known diabetic and hypertensive for 10 years, had a history of stroke 3 months back. Intraocular pressures were 16 millimeters. Best corrected visual acuity was counting fingers. Again, grade 3 to 4 cataract was there, grade 3 cataract was there, and you see dot and blot hemorrhages throughout the fundus. So when an OCT was done, showed a huge macular edema. So as there was a stroke, already a stroke patient within the past 3 months, we gave dexamethasone implant. So intravitreal dexamethasone implant with phacoemulsification IOL implantation appears to be a safe and effective procedure for treating patients with concurrent macular edema and cataract. There was significant improvement in best corrected visual acuity and central macular thickness after surgery in this, as shown in this paper. So the take-home message is a thorough examination of both the anterior and posterior segment is essential before cataract surgery to both prognosticate the disease and to explain visual prognosis to the patient post-cataract surgery, to avoid steroids in patients with glaucoma, avoid anti-VEGF with recent history of stroke, or take a cardiological opinion, and OCT should be and is a must before all preoperative evaluation. Thank you.
Anybody wants to comment about it? I'll, in the meantime, request Dr. Vishali has to go for the presentation. Dr. Reddy, can she present? Thank you.
Sanghamitra, what is your this advice for anybody who's presenting with, moderate cataract but with severe macular edema or moderate macular edema? Would you?
Then probably I would first go for anti-VEGFs or intravitreals and then go for cataract surgery if required, depending upon how much of cataract is there, whether the patient is going to improve after cataract surgery or not. But my first would be anti-VEGFs.
Would you prefer giving the injection intraoperatively during cataract?
So, yeah, we do.